Liver transplant is a complicated surgery involving challenging and meticulous anesthesia. Who can guide us better than Dr. Anil Singh? Having tremendous experience of 15 plus years, Dr. Anil Singh, please. May I request Dr. Jyotsna Paranjpe, Madam, and Dr. Manohar Mane, Sir, to chair this session. Dr. Jyotsna Paranjpe, Madam, is Senior Anesthesiologist, Professor, Head of the Department, Bharati Vidyapit Medical College. She has many articles and research papers under her name. Dr. Manohar Mane is Consultant Anesthesiologist at Ushakkal Abhinav Institute of Medical Sciences and Horizon Hospital. He is ACLS and BLS instructor. I request Chairperson to introduce our guest.
Hello, Dr. Anil Singh has done MBBS, DA, DNB and EDAIC. He is Director, Liver Transplant, Anesthesiology and Critical Care, role of albumin in liver transplantation. In Transplantation Journal, he has got publications. Then areas of interest is again liver transplant and pediatric liver transplant. Major achievements are sitting various liver transplant programs across India, executive member of International Liver Transplant Society. So we have got the best person to explain the difficult topic. Please be seated and be patient. Over to you, sir.
Thank you so much, ma'am. Good evening, everyone. So I'll start up by saying thank you to Dr. Rupali and ISA Miraj and Sangli branch to give me this opportunity to interact with our PG students. So can I know how many PG students are here? One. Please, can you come forward if you don't mind? I think interactive would be fine. Please come quickly so we can start and finish it in 20-25 minutes. It should be of use to you as well. It's no point just me speaking and there's no use. Come quickly. Okay.
Do it fast.
So how many have done liver transplant or seen anybody having any experience of liver transplant? No. So as Neil Armstrong said, your best quote that reflects your approach, it's one small step for a man, one giant leap for a mankind. So this is what I believe in. This, even a small lecture should inspire one of us to become a transplant anesthetist and save lives. In the end of the day, when I come home after doing a liver transplant surgery, I really feel contented. So I am really passionate and I'm here just to find if I could make one of you be passionate or inspired by this to become a transplant anesthesiologist. So what liver transplant basically is the only treatment which is for the end-stage liver disease. It is just summarizing this, no medical treatment, nothing. If one's patient is in end-stage liver disease will help. It is only liver transplant which will help. These are various indications which you all would know, non-cholestatic causes, cholestatic causes, biliary and acute hepatic necrosis. I'll try and go into the main thing. So what decides the outcome of a liver transplant? Basically, the first important thing, which is the most important thing, is the careful pre-transplant recipient evaluation and selection. That's why I don't believe in anesthesia only. Till now, we have all read anesthesia. Work of an anesthetist just to give anesthesia. It's not a work.
Please maintain silence.
You are a peri-operative physician. You have to evaluate the patient. You have to optimize the patient. Then comes the anesthesia part. It is important, but I feel 50 or 60% of anesthesia in every is almost common. So pre-op evaluation and optimization is the most important in any kind of anesthesia, I believe. Leave alone liver transplant. You do whatever anesthesia, you evaluate and optimize a patient, you will have no problems. The problem would be caused by the surgeon, right? Second would be the graft quality. So now here the graft is what I'm talking about is the liver which we are putting into the recipient. So that can be of two types. One is your deceased donor, which ma'am spoke about in a patient who is neurologically dead, or we have a live donor liver transplant. I would not go into the donor surgery because in live donor there are two surgeries going simultaneously. One is your live donor from where you take out the liver. That is a plain hepatectomy. You can go and read about it. The recipient, I'll concentrate on just talking about the recipient surgery. The third is surgical techniques. We have no control over the surgical techniques. Anesthesia techniques, this is where our expertise come, along with the careful evaluation, which is along with the surgeon, cardiologist, nephrologist, whole team is involved in the first step, which is the most important, which we also will be taking care and discussing. So the most common causes of mortality in a transplant is infection, disease recurrence, malignancy, cardiovascular events, and renal. So we would stick ourselves to these important topics to evaluate and go into the surgery. So this is the basic history taking, where diabetes, obviously, you know, insulin, since how much time the patient is taking insulin, hypertension, antihypertensive drugs. So all this history is common as other anesthesia or other things you do. Most important in liver transplant would be nutritional status. Again, I would say it is important for all the anesthesia. If your patient is nutritionally fine, your outcomes will be best. Now, there are many studies which have clearly shown, especially in liver transplant, if patient is sarcopenic, the mortality is very high. The drug history, to optimize your pre-op thing and intraoperative thing, allergies, like always, and MELD and child pug, you'll read it once you go. This is general examination, I'll not. So, important part where I'll go is cardiac evaluation. Two important things which we would want or see in anything is cardiac and lung, right? So first, we'll go into cardiac evaluation. So how do we do it in liver transplant? So history taking you've done, physical examination you've done, functional capacity you'll assess. Can anyone tell me how do you assess the functional capacity? You would have seen all the lectures. How do you assess the functional capacity? Yes, that's the most important thing. If above 4 you know any history, you can go and do anything. At least simple, straightforward surgeries, you go ahead. Here also it is the same. After assessing the functional status, I've already mentioned it's METs, 6-minute walk test, and CPET. Do you have CPETs here? Anybody? Cardiopulmonary exercise testing? Anybody using it, read it, anything? No. So if all this is clear, there's no issue. The other assessment is dobutamine stress echo. We at Nanavati do dobutamine for all the patients. CT angio, I'll tell you in which patient to do CT angio and coronary. So there are risk factors. Like you must have read in all the cardiac risk factors, they are the same. Diabetes, requiring insulin for more than 20 years, biopsy proven NASH, known coronary artery disease, previous CABG done, positive stress test, that is dobutamine stress test I'm talking about. Or other small risk factors are smoking, chronic kidney disease on dialysis, BMI more than 30, hypertension, and non-insulin dependent diabetes since less than 10 years. So how we go about it? In a liver transplant patient, if he's a known coronary heart disease, then you directly go ahead and do a coronary angio. There is no question about it. But if the patient is again symptomatic, you can't do, obviously you have to send it to cardiologist, then there's no role of you doing anything else. And if there are risk factors, so the most important thing, if it is more than 2 risk factors, above 45 years, directly go ahead and do a coronary angiography. But a patient, normal patient of around less than 40 years, no risk factor, CLD, you can just go ahead and do a dobutamine stress echo. Understood? Any questions you want to ask? Because this is the most important aspect when you're choosing a patient for a transplant. This is what decides everything in a liver transplant. This and lung. You will never be stuck on anything else. In answering also, if you answer about your cardiac evaluation and lung evaluation, I think the person should be happy enough that you will be able to carry out this operation by yourself. Because you will be stuck only if person has a cardiac arrest or you're not able to ventilate. So this is the most important thing. Rest, I think everything can be managed perioperatively. Renal issues, you do a CRRT. Post-operatively, you can do. But if there's a cardiac arrest and you are not able to revive that patient, and if you've not done a proper evaluation, then you are in a problem. So any anesthesia you do, my personal view is the cardiac thing and the lung should be done properly, and these are the stepwise I've told you, and these are again CSD. I'll have to run because the time is less. The complications in a liver transplant, pulmonary complications basically are hepatic hydrothorax, which you see in the chest X-ray. It is mainly in the right side. If it is on the left side, then you have to think about it again. It might be TB, it might be cardiac failure, other causes, but hepatic hydrothorax is usually on the right side. Pulmonary vascular diseases, which of two types, portopulmonary and hypoxic pulmonary vascular syndrome, and other comorbidities which you've already run. So how do you diagnose a portopulmonary hypertension? So portopulmonary hypertension is diagnosed by mean pulmonary artery pressure more than 25, wedge pressure less than 15, and pulmonary vascular resistance more than 240 dynes. Now the European Society has come up with a mean pulmonary artery pressure of more than 20, but we still go by 25 because 20 is too low anyways for these patients, and this has sensitivity of 97 and specificity of almost 77%. Above mean, I'm saying, remember this is not systolic. Mean pulmonary artery pressure of more than 50, you will not do any transplant. It is a contraindication because even if you put a new graft, the back pressure will lead to edema of the graft, and there is no point wasting so much amount of resource and the liver. Same, how do you assess this then? So transthoracic echo only gives you right ventricular systolic pressure. It will not give you mean pressure. So how do you go about it? So this is, you do a right heart catheterization if you have anything that patient might have pulmonary artery systolic pressure. If it is cardiac output is high and your pulmonary vascular resistance is normal, you please go ahead and do the surgery. But if there is increase in pulmonary vascular resistance, then you have to put him to a cardiologist or a pulmonologist who would decrease his pulmonary artery pressures. We usually give it for a month or two and then take him for a surgery, right? So there's another entity. See, this is respiratory. These are two different entities, portopulmonary and hepatopulmonary syndrome. Portopulmonary, there is a hypertension there. So treatment of both or the management of both is totally different. That is why you have to diagnose it, especially in PAC. HPS is very easy to diagnose. You do a ABG. If PA2 is more than 80, he will not have HPS. Okay? If it is less than 80, you investigate him for HPS. Have you heard about HPS? Anybody? No. Chalo, I'll continue. So how the most diagnostic test is? From sitting to standing or lying down to standing, if there is a difference of 4 SpO2, suppose he is 96 and his saturation improves on lying down. That's most important. What usually happens? If you stand up or you sit, your oxygenation improves. But here, when you lie down, the oxygenation improves. So if it improves by 4%, our diagnosis is clear. Then you go ahead, do a bubble test, do a albumin, microalbumin aggregated scan. I will not go into it because it's not required for you guys. But this is very important to differentiate between portopulmonary and HPS can be diagnosed very easily. This simple test. So these are the base-like investigation. Like in all other pulmonary, you do a chest X-ray, you do pulmonary function test, you do a SpO2, and you do a ABG. This is done for all the liver transplant patients. So this is the pre-op preparations. So I have cleared it. I don't want to go into renal and everything. Most important thing I would give you right now. If you want further, my DNB class is again on the 6th November. You can see I have 2 classes. The national, please do join for that. I'll try and finish this. OT preparation, you have warming devices, you have forced air warming devices, rapid infusion systems, blood and blood components. We usually reserve 10 bloods, 10 FFPs, 10 cryos, and 3 single donor plasma. You never know when you require it. So this all has to be ready in a blood bank for you to even take the recipient inside the OT. Because once he starts bleeding, we have almost given 80 to 85 bloods within a span of 8 to 10 hours. So this is this much how our liver recipient can bleed. Transducers, T. Do we use T? Anybody uses transesophageal echo monitoring? Nobody? Any idea? Excellent. So what do? In which cases do you use TE? Cardiac cases, okay. So now I think we are, all anesthesia is moving towards the transesophageal echo because it gives you a live dynamic. Like they say, it is not done continuously. You can do it continuously, right? So, sorry. So it's all the cardiac monitors in liver transplant specifically are not good enough. Once the KY is clamped, that cardiac monitor goes out of the picture. Your SVVs, your PPVs, you can't rely on anything. So only thing you can rely on is direct looking onto the left ventricle. You see the filling. You see the VTIs. So this is how you go and assess fluid. It is not easy to assess fluid in liver transplant, and the core of liver transplant is fluid assessment. So it's like that. That's why we are all moving towards transesophageal echo. All cardiac monitors you will see when you go, it's just for mental satisfaction. You see the numbers, you get happy. You see the trend, yeah, trends do help, that I agree, but numbers are of no use in, I think, in anywhere, leave alone liver transplant, CVP, PPV, SVV, just, I think trend is more important than the specific values. Emergency drugs, these are the saviors of you. You undergo any surgery, you use atropine and your ephedrine is always ready. In transplant, this is the list you should be ready with. Atropine, ephedrine, adrenaline, phenylephrine, calcium gluconate and bicarb are already an infusion. Before reperfusion or whenever required, you just start it. Everything should be ready. You cannot waste time during transplant because, like I said, he'll bleed like this and everything will change. You will not have time. I think in small places, there are not good enough workforce with you. Alone or two people will not be able to do. That's why you prepare all these drugs beforehand. So that's why the emergency drugs should be done beforehand. Monitoring again, coming back to it, like ASA before inductions, you do your ECG, saturation probe, EtCO2 for ventilation after intubation, and I think temperature is very important. You maintain the temperature from the starting. You switch off the AC when you're inducing because when liver is not there, your thermal regulation is gone. There is no way you can get the temperature up till the new liver comes in. So if the temperature drops to 33 or less than that, then you are in a big problem. It'll cause that acidosis, that vicious circle will start, and no warmer, no fluid, nothing will get the temperature up. So try that first 6 hours, you get the temperature, maintain the temperature. If it drops, then there's a big problem. Same again, monitoring, we do it. Invasive arterial, CVP, cardiac output, everything is done. But I told you, the best would now be going ahead and doing transesophageal echo. There'll be positives and negatives we can't discuss here, but that is the thing which we are moving forward. We usually use Litcore nowadays. Again, comparison, I'll not get into it. This is important thing which you monitor hourly in a liver patient. Urine output, but till the new liver kicks in, please don't bother. Only see once the new liver has come. Uske pehle jaoge, don't give fluid. You don't have to chase fluid. Initially, it has to be a restricted therapy till the new liver comes in. Okay? Hemoglobin and hematocrit, we do it continuously, seeing the ABG. Either you see losses or you predict that hemoglobin is less, you send it for ABG or lab, whatever you like. Electrolyte, same. Base axis, this all things are done in ABG. So two important things which we do continuously is ABG and TEG. I cannot explain you completely right now because TEG itself is a one class. But that coagulation parameter has to be corrected because all the coagulation is through the liver. Liver is not working, your coagulation is going to be haywire. And during liver transplant, that small 10-15% whichever is working is also cut off during in hepatic phase. That time you have to monitor the coagulation and supplement accordingly. Induction, I'll not go into it. It is a common induction. There's nothing. Just important is the RSI because the patient, there is delayed emptying, and so you have to do RSI and all, and there is ascites severe. So there is already chances of regurgitation. So if Ryle's tube is already there, suck it, take it out, induce and put it again. Don't induce with the Ryle's tube. That is one important thing, or you'll land up with a bad lung. Maintenance, you can use anything. But we prefer to use ISO. ISO is the best for liver. So inhalation drug agent used is ISO. Air, oxygen, nitrous is not used. Narcotic, again, according to, I use BIS as well. So you can titrate your analgesia accordingly. So if you want, best would be remifentanil. If you don't have, use fentanyl as an infusion till you get a new liver and then cut off again. Nitrous is avoided, yes. Antibiotics and immunosuppression are important. Leave it to the intensivist and the surgeon. Lines, these are the lines. We have 2 large bore cannulas. We put a center line and a dialysis catheter. Dialysis catheter is one, it gets a surety that if urine doesn't come, we are ready for dialysis. But initially we had big AVF cannulas which used to expand and give fast fluid. So central line, you won't be able to give fast fluid. So sheath is mainly for fast fluid. It's not just only for predicting a renal replacement therapy or other thing, but it is just to give fluid. Now we are getting, I think 8.5 French has also come. So if you get to 8.5, that also should suffice, but it is better to put a dialysis catheter that helps you. If a dialysis is required, you might be able to do it, right? Outline, okay. Phase-wise, so pre-hepatic, there are 3 phases in transplant. Anhepatic, pre-hepatic, that is dissection to liver clamping. Anhepatic, the time where the liver, they are trying to put the liver in, and the neohepatic is when the new liver is. This is the 3 phases we are. So challenges during initial would be when they are doing dissection. There's a lot of bleeding because of collaterals are there. So you have to maintain the blood pressure. That's why don't give more fluid. There's portal hypertension there. You give more fluid, he'll bleed more. So initially you do a restrictive therapy. Once the collaterals are gone and only the cava is to be separated from the liver, that time you give the blood so that the cava fills up. So initial restrictive, during the cava, you give the fluid. This is how it works in the initial pre-hepatic phase. And coagulopathy, obviously you're managing the ABG and coagulopathy, volume, management, bleeding, coagulopathy, and maintaining blood pressure. Blood pressure, first choice should be vasopressin because portal pressures are high. Try and use vasopressin as much as possible and the NORAD simultaneously. The first choice should be vasopressin and then you shift into NORAD. Intravascular volume CVP approach is good, but values of no use. You track that initial value and keep it there. But after clamping, this is also of no use, right? So TE should be done, and that is advocated by me always. These strategies of low PEEP and tidal volume are all gone, but it is just for our satisfaction. Treatment of coagulopathies by TEG. Please, you learn it slowly. Go ahead and read TEG. That is the future again of all the coagulopathy wherever it is. And it is a very simple graph to learn. It is a dynamic clot formation. It will tell you what to give at the time of bleeding. Then you are not, अरे FFP देना है, platelet देना है, किसी में भी, especially OBS में भी, just immediately tag लगा दो. तुम्हें पता चल जाएगा. There is a normal pathway to follow what to give. So please go and read about tag. Hepatic phase, I told you, from the putting of a new liver. So this is how they put, one is piggy bag and one direct. They replace the cava. That is one technique. The other one is they just put piggy bag, the liver of the other cava and just with the cava to cava side. And this is central. This is the two techniques how the liver are put. I'll not go again. Hemodynamic consideration, I think we have done. So goals would be support the hemodynamics once you've done or your liver is transplanted. Volume should be assessed by T or CVP. The baseline CVP which you have, you can go and reach that. Acidosis should be treated only till in hepatic phase. That acidosis happens in hepatic phase, so you have to be, it is not just -5, it goes to -6 also corrected, because you can't suddenly give us a lot of bicarb, because it is going to increase only. So start treating it when it crosses -5, because it is going to increase. So acidosis has to be treated. But once the liver comes in, please stop treating. Liver will take care of it. Then it is -8, -10, don't worry about it. If it goes above -10, then you treat it. But before, in anhepatic phase, treat -6 also. Start bicarb. Hypocalcemia again, start. Keep it around 1.1 ionic calcium, which is on ABG. Hypoglycemia, keep the sugars high, keep sugar running. Keep it around 200. Don't let it go below 150. No tight control. Okay, support coagulation by TEG, and immunosuppression you have to start immediately before the liver comes in. At the anhepatic phase, you have to give 10 mg per kg of solumedrol. This is what we used to give, but now they're going down, but at least this is the immunosuppression which is given in the liver transplant before the clamp is open. Reperfusion, again, all the toxins, everything, the potassium which is in the liver, which ma'am told about the solutions, comes up out suddenly in the system. So you have to watch out for that. That is why keep potassium around 4, so that you have that space to get that potassium which is coming from the liver, the new liver, which is the solution which you've washed, you have that space. So always try and keep potassium 4 before the reperfusion occurs. Again, there are different ways. I'll not go into this. Let's finish it. Hepatic artery. So after reperfusion, surgeon does the hepatic artery and the bile duct. This is how the liver transplant is completed, and there is a closure, right? I think that should be good enough, because early extubation will help in everything. Thank you.
Thank you, sir. It was a wonderful lecture indeed. Thank you for your time, effort, and expertise, sir.
Thank you, sir, for such a nice, informative, and excellent lecture. This is energy-packed lecture, and I must admire that passion and energy with which you delivered the lecture. I just want for the PG students, is there any fellowship in near us that they can join for the?
I actually forgot. I want for every year. Fellowship is one. So fellowship is everywhere in India. So we in Vedanta, actually we started in ILBS. I have done my residency. I was the first resident of Institute of Liver Biliary Sciences in Delhi. So where we started this, now there is DM as well in solid organ, which was started there in liver transplant specifically. That is the first in India. In Medanta, we have liver, and major transplant centers do have the transplant fellowship as well. So we can do that. And for local people from my side, what I can say is any PGs groups can come, stay for 7 days or so, and learn about the anesthesia and critical care. Those 7 days also would be good enough. So anybody, all the HOTs, all the students are welcome for 7-15 days. We can arrange it with the hospitals, and this can be done.
Thank you, sir. Thank you very much.
I request Dr. Ruta Kulkarni to escort all the dignitaries for felicitation.